I think I'm going to start with a question for John and Dan as representatives of PICME, or ex-PICME. Where do you see, what's the future of the intramural program at NIH in terms of arthritis?
Well, I think that the intramural program at the NIH, and particularly the NIAMS intramural program, or PICME, whichever you choose, is really one that has a great future ahead of it. I think that the spirit of the people who are in the intramural program is absolutely fantastic. I think that the opportunities in terms of translational research that are available, particularly because of the clinical center and because of the emphasis that's being placed on translational research, rightfully, is really exciting in terms of some of the things that I think are in the offing. And I think that the collaborations between the NIMS and other institutes really promise a lot of synergies over the course of the next few years. And certainly, even though I have moved to the Genome Institute, we do a lot of things together. I'm still an attending in rheumatology at NIAMS. I still come to rounds and journal clubs on Fridays. And I think that this kind of interactive environment is really special, and it's something that is really a way of moving things ahead in ways that are unpredictable, but always exciting.
So going back to what Francis said in the beginning, you know, it's important for leaders to have a vision, and it's important for people to be thinking clearly about how they see things going, but there's a lot to be said about what we don't know and then unexpected opportunities. And I guess that's one of the things I've been struck with over the years at the NIH, how you can really turn on a dime. You can really be, the infrastructure allows you to be nimble and to take advantage of, I think in my own work, the concept of epigenetics was raised before. Well, a few years ago, I must say, I hadn't even thought about that. But then I became aware of the work of Keiji Zhao here in NHLBI, and it knocked my socks off. And actually now much of my lab works on this, and it really is because, number one, what you said, that the benefit of the intramural program is that we really have the freedom to act on opportunities that we see that are emerging, act quickly. That's number one. Number two, the NIH is a very collaborative place that over my 30 years here, you know, you can go talk to anyone who's an expert on whatever, and they'll often help you. And then the fourth part, the third, I was up to three. What was I up to? Third, yeah, yes, is the opportunity, as Dan pointed out, of having the clinical center right embedded in our activities. So you hear about interesting patients that illuminate interesting ideas, which again, you know, will change the course of your research. And then, you know, you just don't say, that's weird. You can actually, you act on that. So that's maybe not a very, you know, it's sort of what we said, you know what you don't know, and you don't know what you don't know, and there's some of that.
That counts as a vision.
Okay.
John?
So this is a chance to interview my colleagues. Looking back, John, in terms of your work with Jack, how do you see the NCATS, that is Dr. Collins' vision, enhancing or changing the way that you would have approached the clinical development of that?
Yeah, it's a good point. So I think pretty much anybody who's in the lab, in the back of their mind, they're thinking, this is really cool and really exciting and all this. But I think most investigators do have some vision of trying to relate what they're doing, even if it's very basic, to applied in some way. So I think the key thing is to eliminate those barriers, and as Francis was articulating, to have lessons learned of, okay, if you want to translate this, how do you do it? And I'll give an example. So Juan Rivera made a very interesting finding, that an unexpected finding in his mouse model. And I think, fortunately, because he's here in the NIH Clinical Center, here's Juan Rivera, he's PhD. He's now going to be starting a clinical trial in lupus based on the discovery that he made. So that's the kind of thing that hopefully NCATS will promote, or even allow us to conceptualize those steps. But that's where we want to be. And I think, again, we're privileged being here at the NIH, where that's a little bit easier, but to generalize that would be a good thing.
Sir.
Good morning. Good morning, George. It is morning. Thank you very much for an inspiring bit of wisdom from the patient side. My name is Mark Beckwith. I'm the head of Nevis Outreach, an organization we founded 1 year after my daughter was born. We were told she would be dead before she was 2 years old, but she'll be 15 this month, I'm pleased to say. A question for Dr. Kastner. First of all, I'd like to say how much I admire someone, a scientist who has a degree in philosophy, very much. But from a genetics point of view, and speaking as a layman, I think we're discovering in rare diseases certainly that they sometimes, the symptoms all look like one thing, but then when we look at a genetic basis for them, we find that they're all different genetic bases. And so as the organization that steers the funding for this, and I'm talking about me, not the NIH. If the NIH is the biggest funder in Nevis research, then we must be the second. How would you recommend to me how much weight to put into looking at genetics compared to looking at treatments for symptoms when it comes to finding good outcomes for patients?
Well, that's a great question, and certainly as a physician, I resonate with the idea that we have a patient in front of us and that we have to do something for them in the present moment. And that, of course, does sometimes mean that therapies would be directed towards alleviating pain and symptoms that are associated with whatever it is. And you're right that in a lot of cases, it may be that several different genetic entities, in fact, look very much alike, but turn out to be substantially different. Certainly when I started, for example, with FMF, all of the other diseases that we talked about this morning would have been lumped under FMF or FMF variant or something like that. And certainly, for example, the patient that I talked about from Louisiana, where the husband had died of what was said to be FMF. Well, it looked like FMF. Really, when you came down to it, clinically you could tell it wasn't the same thing. The attacks lasted like 6 weeks at a time for that patient who died versus 1 to 2 days for FMF, et cetera. So certainly things can look like they're the same thing, even though they're different genetically. But I think one does have to bear in mind you are starting out with a person in front of you and you have to deal with some of their symptoms. Nevertheless, I will say, at least based on the experiences that I've had, it does make a big difference what's the underlying cause as to what you would do. And just certainly other examples that we can think about, the cancers and understanding what is the biologic basis for particular tumors. It may be that a subset of patients has a somatic mutation in one gene and a different subset has a mutation in another gene, and only one group will respond to a certain treatment. And so it is really, really important to understand these things at the most basic level. So I guess that I would say that, for someone who's in a patient advocacy group, that you have to think of both sides of it. And I can't say black or white, yes or no, heads or tails.
I certainly appreciate that, yeah. Thank you.
Go ahead.
I'm Steve Teitelbaum from Washington University, and this has been a great morning. And it's been a great morning because of, to my mind, primarily because of our advocates who told their personal stories. but it's also been a great morning because we've had the opportunity to hear wonderful translational information. But I have, I think, a greater challenge for us than translation, because translation, in a sense, to lay people is an easy story to sell. People who have, particularly those who have diseases within families, will always buy into the hope that my disease will be affected by the science that is being done. What is more difficult, and I found this when I was advocating for embryonic stem cell research, both nationally and in the state of Missouri, is to get across to lay people the concept that science is unpredictable, and one must be patient for the payoff of basic research. And that is, there are so many examples, and John and Dan, you've given examples of, particularly Dan, of a focused disease. John, you started off with your JAK experiments, in a sense asking a fundamental question that turned out that there was a disease ultimately that you could adapt this to. I think it's very important that we realize that because of the unpredictability of science, to just make a focus only on those which are, in our own vision, are translatable is a mistake, because so much of what has ultimately become translatable, and there's so many examples of it, have just been an interesting question that scientists approach. This is a tough thing to do. I have found that the concept, selling the concept of the non-predictability of science to lay people is very, very difficult. But I think that if we're going to make great advances, that concept has to come across.
I'm going to ask Beach if he would comment, since you've been on both sides of that. You've seen the science that we've supported. You've also been a patient. Would you care to respond? Or?
Yes, I can respond to that. The idea, the big word that came across was hope. People who have some type of disease that doesn't have a distinct solution in terms of treatment, they're working on this hope button, and it's a good button to have that hope that something eventually will come across that will work for me. And I think the idea of the patient, my being a patient, and when I saw things about interleukin-1, interleukin-2, I would take it into my rheumatologist and say, what about this? What about that? And I think my rheumatologist over the years got a little tired of me bringing in things that I found in newspapers and things of that nature. But my hope was so sincere that there would be some solutions, for me, and there have been. Now, just think, 44 years is a long time. A lot of people in here aren't quite 44 yet. But this is a long time to be struggling with something that is iffy in terms of an answer. But I think the notion is that you have to allow people to find their own level in terms of how much they believe in the quickness of a solution based on the investigations that our scientists and researchers are dealing with. Did I get it for you?
Let me just add that even though I hate to agree with my friend Steve Teitelbaum, it happens occasionally, I do agree with you, the unpredictability, but also, as you know, virtually all of the institutes at the NIH do have as a core value basic research. And I think it's incumbent upon us to show examples of where basic research findings in one area have a tremendous impact in another area. Two of the ones that I use that are immediately accessible to people are the first is in structural biology. I mean, why would anybody do structural biology? But many of the advances in AIDS therapy comes from structural biology, and even now in cancer therapy comes from structural biology. With regard to our institute, if you think of the origin of the anti-TNFs, those had their origin in tumor studies that were being done in cachexia mice. So these are the examples, and I think that it's through examples like that that people can gain a better understanding of why you talk about having this balance, as Dan couldn't exactly define to Mark Beckwith. Where do you draw the balance? We don't know exactly where you draw the balance, but we do know that if you don't invest in basic research as a core value, 20 years from now, you won't have much. If you don't invest in training, 20 years from now, you won't have much. So I agree with you in terms of the unpredictability, but also as a core value for bringing about discoveries in the future. I think we have to adhere to that and really profess that and use examples of that. So it's very much in line with what you're talking about.
If I could maybe just add something to that, just in the sake of time, I was not able to really go into all of the background in terms of the wonderful treatments that, at least in some cases, we've been able to offer the patients where we found genes that are associated with their illness. But certainly that wouldn't have happened if it had not been the fact that there was a parallel universe, in essence, of basic immunology that was identifying and elucidating and explaining cell signaling with cytokines, and then a very active biopharmaceutical industry that was developing agonists and antagonists that could target those kinds of molecules. And so we were quite fortunate in what we were doing, and the patients that we were working with are quite fortunate that we happen to have that other infrastructure in place at the same time.
One last question.
Yes, we are very lucky to have several options for therapy for rheumatoid arthritis. You could target the T cells, you could target the B cells, you could target the cytokine which causes inflammation like TNF. So for a patient with a high level of rheumatoid factor, so which options is the best? Are we knowing enough from the clinical studies that are going on that might help to identify an approach that might reduce the cost, because cost is a major issue also?
Well, I'll at least say a few words about that. Certainly, one of the important things that needs to be done is to have some head-to-head comparisons between some of the different agents. And of course, that's a place where the NIH intramural program can play an important and unique role, because certainly the studies that are oftentimes conducted at academic medical centers, simply because of funding issues, a lot of times are paid for by the pharmaceutical company, and no pharmaceutical company is going to want to have a head-to-head comparison of their agent with someone else's agent. So certainly, although we don't want to simply be doing, as one friend once put it, Coke versus Pepsi studies, on the other hand, there is at least some role for comparative effectiveness studies in trying to work this kind of thing out.
I think the other point to be made is that we're in a different world than when all we had was 20 aspirin. Mm-hmm. And so it's amazing I've seen this from the side of a physician and hearing it from the side of a patient. But I guess what we really want in the end is we want a cure, right?
Cure,
and
yes.
so we're not there yet. And so I think that's, again, back to the point that was made. That's why you do the basic research. This is where we all really want to go. We want to be thinking about different ways of therapies. I mean, one could even think about maybe approaching diseases like rheumatoid arthritis with consolidation therapies, hitting hard up front. We know it's a little bit tricky because if you add 2 biologics, you end up with infections and not an advantage in terms of therapy. But obviously we've got lots of great therapies, and that's terrific, and it's incredibly edifying to see this. But we've got a long way to go.
Thank you.
That's great. I think we'll close with that. thank you all. That was, I think, one of the best